Sir, yeah, people are joining, sir. Hello.
Kashi, you made a small election campaign meeting here. Everybody is contestant.
Bajania sir, where are you? Bajania sir?
I'm in Lucknow.
Lucknow, yeah.
Tomorrow morning we'll come to Nagpur.
Acha.
Sir, Anil sir, on 5 minutes, sir. Sir, people are joining.
Yes, sir. No problem.
Guru sir, 5 minutes.
దీపక్ ని చెక్ చేస్తున్నాం దీపక్ చెక్ చేసుకున్నాం ఇది
చేసుకున్నా సార్ అంతా రెడీగానే
ఓకే
Shanti joined. Hello, Shanti, Dr. Shanti. Shanti is not joined.
Yeah, I have some. Transferring. What else is Anil Kumar.
Panelist link కూడా పెట్టండి దాంట్లో పర్లేదు పెట్టండి డాక్టర్ దీపక్ హలో
దీపక్ అన్మ్యూట్ చేసుకోమా
దీపక్ యా I'll be starting in 2 minutes. Just focus the slides, okay? Deepak?
Okay.
Sir, Anil sir, I'm starting the session, sir. Sir, people will join.
You can start. Okay.
It will become late, I think. People are joining.
Start off.
Respected teachers, doctors, welcome to the 10th successful UCME. With the help of Dr. Anil sir and Guru Prasad sir, we are successfully reaching the national level. So today our guests are Dr. Anand Keshavan sir. Sir, welcome you. Dr. Naranappa sir, my HOD sir. Hello. I'm happy to see my HOD and Dr. Ramesh Bhajan sir. Yes, sir. Welcome to the AP Pedicon sir. Sir, not your CME sir. Yeah. Sir, first of all, just a brief introduction. Dr. Anand Keshavan sir is a professor of pediatrics, GMC Thrissur, is a chairperson, is a IAP National Vice President 2020, is a past National President and Secretary of IAP Neurology Chapter. He is a Chief Editor, IAP TB of Pediatric Radiology, 4 years in Pediatric Neurology and Recent Advances in Neonatology, and is a National Convener of IAP PD Speech Program 2021 and 22, and Joint Secretary of IAP ID Chapter 22 and 23. Dr. Anand Keshavan sir, heartily welcome sir to the APO CME sir.
Thank you.
Yeah, sir. Next, Dr. Naranappa sir, please.
Yes.
As Naranappa sir, you are my trainer. Today I was there because of you only, sir. You're teaching everything.
So nice of you.
I was very happy to see my teacher as a moderator, sir. So as
I am proud of you. I am proud of you, Kashi.
Thank you, sir. Sir, as Naranappa sir, no need of introduction. He is known person for everywhere. As I'm seeing personally, I was worked with sir for almost 3 years. So sir was who was trained as academically, and he trained most of the postgraduates across India. A little introduction about sir. He was a teacher since 30 years, UG and PG and PhD from JSS Medical College, Mysuru. He's a National IAP Chairman 2019. He's a State IAP Neurology Vice President 2016. He's a State IAP in Adolescent Chapter Vice President 2017. IAP Karnataka President 2014 and 15. IAP State Infectious Disease Chapter President 2013 and 14. IAP State Respiratory Chapter President 2008 and 2010. SAR was organizing chairman for the Pedicon, State Pedicon 2008 and 2009-14. In Neocon 2009, I was there. And sir has more than 100 publications, sir. Sir, I welcome you, sir. And it's an honor to have you, sir.
Thank you. Thank you so much, Kashi. Thank you,
Yeah.
Anil.
Thank you,
Anil,
thank you, sir.
thank you
sir.
so much for inviting me.
Sir, no, sir. You are thankful for accepting our invitation and joining us, sir.
Okay. Guru Prasad, thank you for inviting me.
Doctor, next slide, sir. Next, our moderator is Dr. Ramesh Bajania, sir. He was executive board member of CIP 2022, 23, 24, sir. He is a chairperson of Environmental and Child Health Chapter 21, 23, sir. Secretary, Environmental and Child Health Chapter 2019 and 21. Organizing chairperson, Pedivicon 2016, 21 and 23. Sir was a delegate international conveying on lead poisoning in India, and many more are there. So, and he was a chief organizing secretary for Gujarat Pedicon 2020, sir. Sir, Ramesh Bajani, sir, I welcome you, sir.
Thank you,
Hello.
Kashi. Thank you for this opportunity. I'm traveling and I'm in the car. So
Sir,
my best wishes for this UACAB. Thank you so much.
Sir, this UACME is to encourage the young talented speakers, sir, all over Andhra Pradesh.
Yes.
So we almost we till now almost 40 to 50 speakers has been presented the seminar, sir. So we are giving them to the
Excellent.
conference, sir.
Excellent.
Yeah,
Kashi, Dr. Pakul Parekh is conveying his regards, Kashi. Kashi
Bandaru. Sir, yes, sir.
How are you?
Sir, fine, sir, sir.
And
Nice
Dr.
to see you. And Dr. Ajay Srivastava, your vice president.
Sir, sir, hi, sir. Sir, good evening, sir.
So best wishes to UACAB.
Yeah, sir. Successfully, sir. Sir, I request Dr. Anil, sir, to speak little about UACME. One or two words, sir, and welcome our all delegates, teachers, and moderators, sir.
Good evening, everybody. I think today is a great day. We are fortunate to have all the distinguished guests, Anand Keshwan sir, Narayanappa sir, and also Ramesh Bajani sir, who are academically very active and has contributed a lot to the pediatrics as far as academics is concerned, and also has contributed significant contribution for the IAP also. And we are also fortunate to see the Ajay Srivastava sir, Bakul sir, and other things. So thank you for joining us, though it is a coincidental thing. Sir, we are really fortunate to have all the three distinguished faculty and moderators today. And about UACME, we are almost from 3 years we are running it successfully, sir. And we are given opportunity to most of the young talent. These are the first time speakers who are coming on the platform. And some of the good speakers are selected and we are given opportunity in our state conference so that we can encourage the young speakers so that they become future or AP academicians, everything. So with this background, we are continuing the UACME, and last 10 UACME was conducted by Kashi, and we have very good attendance. The attendance is improving every year by year. And the leadership of Kashi, I think we are having 300 to 400 viewership is there, and excellent speakers are coming out, and younger generation talent is identified every time, and we are identifying different specialties, neurology, respiratory, and everything, endocrinology, everything we are taking care of. And I think the last two also will do successfully, Kashi. All the best for Kashi. And I request all the viewers, all the participants to utilize the opportunity because excellent academician is there, especially neurology, the sir has contributed. Both Narayanappa sir and Anand Keshwan sir, who was academicians, who are in teaching, who has trained n number of students in his successful career. And Kashi itself is an example who is standing with a student of Narayanappa sir. I request all of you to utilize them and I once again thank Narayanappa sir, Anand Keshwan sir, and Ramesh Bajani sir for joining us, accepting our invitation and blessing us to UACME platform. Thank you, and I wish all the participants a happy learning. Thank you, sir.
Thank you, Anil. Thank you for the opportunity.
Sir, Dr. Guru Prasad sir. Hello.
Guru Prasad sir, airport lo
Okay. Sir, Dr. Anand Keshwan sir, one or two words, sir, before starting the session.
Very good evening. Respected State President Dr. Anil, Dr. Program Coordinator Dr. Kashi, my friends Narayanappa sir, Dr. Ramesh Bajania, Sai Prasad, and also of course Dr. Guru Prasad sir, and all my dear friends. It is very happy to see that you are organizing a UACME to promote our younger generation. It's a novel idea, good idea. So I congratulate the complete organization team for this wonderful activity. And also, I thank the organizer for giving this opportunity to chair this important session. As such, today's topic also closely related to my heart because it's something related to neurology, tropical infection related to neurological problem. The second one is, I think, tuberculosis meningitis. As we know, because many disease affecting neurological problem, because nowadays our ICU and the PICU is occupied mainly with children suffering from encephalitis, different types of encephalitis syndrome, neurological infection, and majority of them we know they are escaping, but somehow little bit morbidity. So we have to detect it early, we have to treat it efficiently, and so today's topic also very aptly selected. So I congratulate for the entire team for selecting good topic and also for selecting excellent speaker. I wish the program all the success. I once again thank you the organizer for inviting me to chair the session. Thank you. Jai Hind, Jai IAP.
Thank you, sir. Thank you, sir. Sir, Dr. Naranappa, sir, one or two
Yeah.
words.
Good evening, everybody. At the outset, I congratulate Anil Kumar, Guru Prasad, and Kashi for the wonderful task they have taken to encourage youngsters to come out and present their talent. And this is how our tendency, the tradition should go on. That is the best way, is the best example where we are really insisting that youngsters should compose. Young speakers should be there in all the conferences. 30% should be for youngsters every year. That will boost their morality and they will be the future stakeholders of IAP. So wonderful idea. Hats off to you all. And today's topic is nicely tropical infections. They are very common and common issues. In fact, the WHO has made an entity called neglected tropical diseases. Nearly 20 diseases are enumerated under the heading of neglected tropical diseases. That means to say, malaria is a tropical disease, TB is tropical disease, and Japanese encephalitis, typhoid fever, respiratory infections are all tropical diseases. But certain of them, like for example, all of them have got some program. So malaria has got National Malaria Eradication Program, TB and TEP. So like that, all of them have given trust. So WHO has realized and made 20 issues. For example, dengue fever. It is a neglected tropical illness. So where the programs are not there for that, the allotment is not there for that. Preventive aspects are not very much strengthened, though we know it. So that is why it is put under the neglected tropical disease. All helminthic infestations, we have a lot of helminthic infestations in our country across globally, which are not given much importance. So all of them and come under that category. It is nice to see the tropical infections which affect the brain of children especially. The mode can be any type. All these days we were thinking just encephalitis, encephalopathy like that. But we must understand the pathophysiology and pathogenesis of brain damage in all tropical infections. Then only we will be able to treat them better. So in this direction, congratulates you for having chosen this topic. And nicely, we have a good youngster, Sai Deepak, who will be highlighting this. And he's a qualified neurologist. And again, I thank Ramesh Bajania is there, Guru Prasad is there. Anil, thank you. Thank you for the opportunity. And we will go ahead now. Yeah, over to Kashi. Kashi was my proud student, a very good outgoing student in MD. He did his intensive care under Dr. Basuraju and very committed, knowledgeable pediatrician. I am proud of you, Kashi. Keep up the tradition and go ahead. All the best for you.
Thank you, sir. Thank you, sir. Thank you. Sir, Dr. Ramesh Bhajan, sir.
Few words from you, sir.
Minutes of, sir.
Ramesh Bajane, sir.
Hello.
He is driving.
Hello. Yes. So I'm really impressed with this initiative because to give chance to youngsters, I mean, you create a future batch of academicians, and to get a chance with dignity, mentoring by seniors. I mean, it's to me, it needs a loud round of applause because wherever you see the youngsters, I have asked so many people that they say that we don't take interest in Central IIP because we don't get chance. So, and this is something extraordinary. Now, about today's session, we also did this session with experts under the aegis of our SDPA, Gujarat Pediatrician Groups. If you look at epidemiology, the estimating the global burden of tuberculosis disease in children is really challenging due to the lack of a standard case definition, the difficulty in establishing a definitive diagnosis, the frequency of extrapulmonary disease in young children, and relatively low public health priority given to TB in children relative to adults. Even low sensitization on the part of our colleagues as well as public. So I am very sure that this will enlighten young minds and senior pediatricians alike. And if they are sensitized, when to suspect, how to suspect. There are so many new developments, and I'm very sure that our learned faculty, she will do justice to this topic of tuberculosis in children, latest updates. So I'm very sure about Dr. Santi Meher. My uh, heartfelt gratitude and thanks to Dr. Anil Kumar, Kiriti sir, Rajsekhar sir, and all the office bearers of uh, Andhra. Kesavalu sir is my EB colleague. So wish all the best to today's CME, and I wish for the future also. So please continue grooming the young minds. Thank you so much. Thank you once again for this opportunity.
Thank you, sir. Thank you, sir. So shortly, sir. Thank you, sir. So it is a nice blessing for our young speakers, sir, especially. So we are targeting. Dr. Sai Deepak, please introduce yourself. I welcome to the AP 10th UCME. Introduce yourself and start the program.
Yeah. A very good evening, one and all. I am Dr. Sai Deepak. Finished my MBBS from Siddhartha Medical College, PG from Siddhartha Medical College. Anil Kumar sir is my professor. I'm very thankful to Anil Kumar sir for giving me an opportunity, and Kasi sir also, and all the IAP AP team. I did my fellowship in pediatric epilepsy and neurology from Bharati Vidyapit, Pune under Kavita Srivatsava and Sureka Rajudaksha ma'am. So I'm currently working as a consultant pediatrician, pediatric neurologist in Andhra Hospitals, Vijayawada. So with this, I want to start the topic today. Is this entire screen visible?
Visible.
Yeah, visible, Sai.
Okay. Send it down 1 second. Yeah. So today, these are common tropical infection affecting brain. So this is a very huge topic. First of all, there are lots of tropical infections, and they infect brain in a very different mechanisms and in different presentations. So I want to take it in a case-based approach rather than more theoretical. So these are the recent real-time case scenarios that I'm going to take you through. Yeah, these are the common pediatric tropical infections. Usually the respiratory infections are enteric fever, dengue, malaria, rickettsial fevers, mumps, tuberculosis, Japanese encephalitis, chikungunya. Lastly, I want to include just a summary regarding latest updates regarding neurocysticercosis. It's also a very tropical CNS disease with a huge burden. So how can they target the brain? They target brain by causing acute meningitis syndrome, subacute or chronic meningitis syndrome, They can cause acute encephalitis syndromes. They can cause encephalopathy with systemic infections, or one important entity which one should not forget is post-infectious syndrome that are usually immune mediated. When to suspect? Next question is, there are lots of children you will diagnose as dengue or enteric fever or malaria or whatnot, everything. When to suspect? So pediatrician or any treating physician should suspect when there are high-grade fevers with or without seizures, altered sensorium, or sometimes excessive drowsiness. You should not miss this entity that can attribute to a mild encephalopathy, persistent headache, neck stiffness, persistent vomitings, ataxia, swaying to one side or other side, squint, nystagmus, facial nerve involvement, acute onset facet paralysis, and neuroregression. When such presentation, such symptom or sign occurs in any child presenting with or without fever, you need to suspect that CNS could probably be involved. Firstly, as we have seen here, I just want to complete meningitis very quickly, and I want to go through other cases in detail. So usually in acute meningitis syndrome, they usually have a sudden onset. They present with high-grade fevers. In neonates, the presentation will be poor feeding, feed intolerance, lethargy or irritability. They may have high-pitched cry, fevers, and they may seize. One important sign could be a bulging anterior fontanella in infants. Older children present with acute onset fever, meningismus, photophobia, altered sensorium, seizures, any motor deficits, and signs of elevated intracranial pressure. As a rule, children with fever and seizures or convulsive status epilepticus, they warrant a high clinical suspicion of meningitis, especially less than 1 year. A child with meningitis should also be examined for other sites of infection, such as otitis media, pneumonia, endocarditis, sinusitis, skin infection, or joint infections. How will you approach? You do protein CBP, CRP, procalcitonin, early CSF analysis, and also you should send biofire, the bacterial and the viral panel. Bacterial PCR, when processed early, has a sensitivity of nearly 100%, specificity of 98%. CSF analysis gives clue. So if you can just go through this, predominantly neutrophils and cells 100 to more than 1000, suspect bacterial, glucose is reduced, that is important. Partially treated meningitis, you will have 5 to few hundred cells. Glucose may be reduced, mildly elevated protein, lymphocytes may be present, but predominantly neutrophils. Tuberculosis, predominantly lymphocytes, cell count will be less than 500, raised protein, glucose will be reduced. Viral encephalitis, 10 to 500 cells, neutrophil predominant, the lymphocyte predominant, neutrophils can be present, proteins may be normal or raised, glucose is usually normal. And imaging, you should always advise MRI brain with contrast, preferably. There are few certain conditions where you should avoid contrast. I'll tell you later. Empirically start antibiotics, ceftriaxone, third generation cephalosporins. If very sick, you can go with vancomycin. Management of raised ICP is essential. You should treat the seizures and also symptomatic or supportive care, euthermia, euglycemia, euvolemia is very important. Fluids, steroids. When to use steroids is one thing. If it is tubercular, you should give steroids for 6 weeks to 8 weeks. Dexamethasone is preferred, followed by oral steroids. If it is bacterial, current guidelines, current literature does not support routine use of dexamethasone unless you are suspecting Haemophilus influenza type B. Next is subacute or chronic meningitis. From here, I want to go in detail. Taking TB as prototype, this is a case of 6-month-old baby presented with acute onset neuroregression along with on and off history of low-grade fever since the past 2 weeks. Baby became loose, lost head control, head holding. Previously, he is able to attain all the development as per age. So there is definite neuroregression noted. On examination, head circumference is normal. Infant is floppy in a pit frog posture lying on the couch. Deep tendon reflexes are present. That indicates that it is not a lower motor type of hypotonia or no dysmorphism. Cranial nerve examination is normal. He is not sick. He is actually fine, feeding well. BCG scar is present. So what will you suspect? With such neuroregression, 6 month, chronic on and off fever, first thing we suspect is due to infection etiology involving brain. It could be meningitis, it could be TB. And one more thing you should not forget in such instances is a mitochondrial disorder. Anytime you should have it in your mind. Investigations, we went ahead with routine bloods, CSF, MRI brain, MR spectroscope, because to rule out mitochondrial, where there will be an inverted lactate peak. These are the investigations. Ionized calcium was 2.4, it is elevated. Serum calcium is also slightly elevated. You can call it in the higher end. CSF showed 28 cells, neutrophils 70, lymphocytes 30, glucose and protein are normal. As the calcium is high, we went ahead with parathormone, which is slightly low. D3 and phosphorus are normal. Thyroid, routine thyroid function test was normal. Surprisingly, you could observe his serum, his plasma is quite milky, which surprised a lot. CSF routine panel was negative. We went ahead with gene expert TB quantifier on goal. Before that, we went ahead with MRI because it's neuroregression that showed, and CT. I think my pointer. Can you see? Yeah. Yeah. Now you could see a tuberculoma. It's space occupying lesion here, and CT showed basal exudates here. So it was reported likely granulomatous disease could be tuberculosis. Gene expert proved it. It is sensitive to rifampicin. We went ahead and started ATT. Simultaneously, we sent gastric aspirate, CBNAT, which is positive for tuberculosis. ESR was elevated. That is one indirect clue. Montux was positive. And samples of blood has milky appearance, and there is hypertriglyceridemia as well. Fundus is normal. Rule out any storage disorders because I could feel spleen tip is palpable in that case. So I'll come to the discussion later. So how could TB affect brain? It could cause tuberculous meningitis. It could cause a tuberculoma or granuloma, miliary or leptomeningeal granuloma, tuberculosis abscess, encephalopathy, cerebritis. One important entity you should not forget is vasculitis and infarcts, and cranial neuropathy, and stroke, and spinal tuberculosis. This is one interesting case from Bharati Vidyapit, Pune. I'm not just detailing, I'm telling briefly. 9-year-old child who presented with acute onset swaying. That is the presentation. That is the only presentation with fever on and off. We never thought the fever subsided actually after 1 week after the fever presented with ataxia. Initial imaging showed cerebellar diffusion restriction, cerebellar lesion, and also certain hyperintensities here. So it's basically stroke. It's basically stroke, acute infarct with restricted diffusion noted in the posterior circulation area. So we thought posterior circulation stroke. See, restricted diffusion noted. On ADC, darkening also is noted. We went ahead with all MRA, MRV, everything that showed some narrowing of the vessels. We went ahead with Clexane, that low marker heparin, slightly improved power. We discharged. Again came back. Repeat imaging showed periventricular oozing with hydrocephalus and gliotic area of the previous infarct, and there are exudates that could be seen. So these are ling-enhancing lesions and basal cisterns suggestive of tuberculoma. Started on ATT and this child improved better. Still, there is a lot of morbidity due to delay in diagnosis. And TB meningitis usually present with stagnation or loss of developmental milestones. Bulging anterior frontanella, fever, cough, altered sensorium may be present. First stage consists of non-specific symptoms like fever, headache, irritability, drowsiness, malaise, poor weight gain, or weight loss. Second stage is the one where usually they are picked up. They present with lethargy, neck rigidity, meningeal signs, hypertonia, seizures, vomiting, neurological deficit, hydrocephalus, and raised ICP. Movement disorders, cranial nerve palsies, mostly sixth nerve, and vision loss occur later. And stage 3 eventually present with hemiplegia and decerebrate decorticate posturing. MRI clues is very important. Basal exudates, basal meningeal enhancement, communicating hydrocephalus, infarcts, and tuberculoma. So this first child, which I mentioned, the 6 months old baby, was started on ATT regimen for intensive followed by continuous phase, and pyridoxine was also supplemented. Steroids were given for 6 weeks. Child is doing well on 5 months follow-up, improving tone, able to hold neck, able to roll over now. Repeat MRI was planned in the next visit after 6 months. So in diagnosing TB, you need to have high index of suspicion and subtle clinical and investigation lab clues will help in arriving at your diagnosis, and early initiation of treatment will give better outcomes and less morbidity, especially in CNS involvement. So TB is a treatable neuroregression disorder which has good prognosis when treated early. One more query you must be having is why there is hypercalcemia and why there is hypertriglyceridemia. Literature review also supported that these two entities are features of many granulomatous diseases like tuberculosis and sarcoidosis. Third presentation is common currently.
Sorry, Deepak. At the end
Sir.
of these two, can I interfere to 1 minute?
Yeah, sir.
And these two nice cases that you have presented, 2 cases of tuberculosis, 1 6 months with a floppy child.
Yes, sir.
Unusual when you have so much of exudation and tuberculoma in MRI. And of course, undoubtedly, CBNAT was positive.
Yes, sir.
And no doubt it is tuberculosis. When the child comes with floppy infant presentation, though 2 weeks history of fever is there, very unusual. We see spasticity with brisk jerks, decortication, decerebration very early in life.
Yeah.
This floppiness, can it give a clue to the different pathogenesis? Though tuberculosis it produces neurology in different way, could it be like a edem following TB or peripheral neuritis with TB, things like that? Do you commonly see that floppy infant in TBM?
No, actually, with this child, what my initial clinical suspicion was something, am I dealing with a metabolic disorder, something. That is the primary. So we send the basic metabolic screening like ammonia, lactate, everything were normal. And that's the reason I included MRS in neuroimaging that could give a clue towards some metabolic, not all, sir. So first we thought that we send, what I do is I'll send a basic metabolic profile first. That includes your blood gas, which showed pH. Acidosis can be found out. Lactate can give a clue. Ammonia can give a clue. Or any subtle clues you can find out. And urine ketones can give a clue towards some acid disorder. But we didn't think of TB initially. MRI clinched the diagnosis.
Yeah, and you have evidence also, no doubt. CBNAT. And what is the cause for hypertriglyceridemia and also?
Yeah, that actually misled us, sir. Actually, we thought that hypercalcemia is there, hypertriglyceridemia. We evaluated in terms of familial hypercholesterolemia as well.
Yeah.
That we sent whole exome as well, but that turned out to be negative in this child. So literature showed that there are few cases, especially hypercalcemia is more associated with TB, whereas hypertriglyceridemia is relatively associated more with sarcoidosis. rather than
Uh-huh.
tuberculosis.
Correct.
So that is one entity, and we attributed that the mycobacterium, the cell wall layer is lipid, is
Yeah,
glycan,
lipid. Tuberculoxylic acid.
sialic acid.
Mm.
So
Lipid
anything
layer.
related,
Yeah.
we searched the literature, but TB is not so supportive. But most commonly in granulomatous diseases, especially sarcoidosis, show association with
Correct. Correct.
hypertriglyceridemia. Actually, we want to report this actually.
Okay. Okay. Please go ahead, Sais.
Sure, sir.
Nice. Yeah. Okay.
Coming to a third entity, how a tropical pathogen can infect brain, which most of us see. Currently, this is the season that is going on. Acute encephalitic syndrome. I want to take dengue as a prototype and discuss a couple of varied presentation of dengue in two extreme age groups. A case 1 is a 2-year boy presented with left focal fever-provoked status. So how to get rid of this video for? I could not. Yeah, yes, sir. Now I. Yeah. 2 years boy presented with left focal seizures, fever provoked actually, with history of fever, high grade fever since 2 days. He had rash over the body at the time of presentation, blanchable rash, flushing. He is treated according to status protocol, continuously seizing despite first line and 3 of the second line anti-seizure medications. He was intubated, started midazolam, connected to bedside EEG. His routine bloods, dengue, NS1, ELISA, and IgM were positive. We connected to EEG that showed continuous runs of high amplitude spikes followed by some suppression in between. And that child also had clinical seizures with subtle lip smacking that could be noted even on these three, even on midazolam. So eventual birth suppression was achieved with ketamine infusion and high-dose phenobarbital and multiple anti-seizure medications like perampanel, topiramate, everything we gave, and eventually this is the EEG that we could get. Some burst followed by suppression. He seizure-free clinically and electrically for 24 hours. We gradually weaned the sedatives and stopped. MRI was done once he was hemodynamically stable. That showed basal ganglia lesions along with lesions in the cerebellum. So suggestive of dengue encephalitis. He was in encephalopathic even after weaning the infusions for some days. Supportive care was provided, eventually improved his sensorium over the next 5 days. However, some neurological deficits are present. He could not recognize well his, but seizures wise is controlled and we are able to extubate. This is the EEG after that, showing some intermittent sharks over both hemispheres and background asymmetry that could be appreciated significantly. I'll tell the management. And second case is a 16-year-old girl recently in our ICU currently with sudden onset weakness of lower limbs and then upper limbs, unable to walk and unable to lift her hands over 1 to 1.5 days. History of tingling and numbness present in the limbs. Lack of sensation of passing stools. Urinary retention noted on admission. Child had high-grade fevers for 2 days. She also had difficulty in swallowing and become dysphonic. Her voice is also reducing gradually and difficulty in taking breath. We initiated NIV. Power in upper limbs are 1/5, lower limbs 0. She required PP, positive ventilation. DTRs were absent, plantars are absent, abdominal reflex is absent, extraocular muscle movements are normal. No seizures, however, child is bit lethargic. She's mild. So clinical suspicion, so infectious demyelinating disorder. Our suspicion could predominantly involving spinal cord because of sudden onset flaccid paralysis, along with upper limb also is involved and also bowel and bladder symptoms and tingling and numbness. So some neuropathic component is also there. So investigations, we routine, apart from routine fever profile and blood investigations, neurologically we advised NCS, neuroimaging, but we could not do as the initially as the child is on respiratory support, and CSF was planned. So NCS shows demyelinating type neuropathy, predominant involving only upper limbs. Lower limbs are normal, surprisingly. And dengue is positive NS1. MRI showed signal changes involving. We did MRI spine and brain. MRI showed signal changes involving entire cord, predominantly cervical and high dorsal cord, continuous long segment involvement. Afterwards, the lower cord, only patchy involvement is there. Brain showed subtle signal changes in the thalamus region, and brainstem, that white I marked in the third MRI image, pyramidal tracts are hyperintense. So likely could be dengue encephalomyelitis. CSF shows 18 cells, lymphocyte 90%, proteins are 85, glucose are 62. Viral panel for CSF sent, it's awaited actually 3 days back only. Still treated with IVIG, 2 gram per kg over 2 days and supportive care. Significant improvement in power after 2 days of IVIG, and the child is also off respiratory support. And one more clue is CBP is showing subtle thrombocytopenia. I think 1,10,000 or something like that. I think 1 lakh. I think feeding improved. Speech tremendously improved after we finished IVIG over 2 days. That is, and 4 days after completion, she's speaking normally. She's eating everything. Only thing is her lower limb power is a bit on the 1/5 only. Upper limb tremendously improved. This is the child. You could see after 4 days after IVIG, she is lifting both her arms, but lower limb wise, she could not. Like we're asking her to move, but she could not move. Actually, just only slightly she could move with very difficulty. Only 1/5 power, you could say.
The typical dengue ADEM.
Yes, sir. Yeah, dengue
Both
more
involving spinal cord, peripheral nerves.
this is more like rather than Adam, I could myelitis directly involving
Encephalomyelitis.
Yeah.
Typical.
Now she is doing well. Other than that lower limb power, he is on physiotherapy. I think she will catch up over 1 to 2 weeks at least.
So MRI has decided the diagnosis for IVIG.
Yes, sir. Actually, MRI has this. No, actually, we gave it initially only, sir, because first day we could not do because she required HFNC support. We could not shift the child. After 24 hours of IVIG, once she is off respiratory support after 2 days, then only we could get the MRI done for this child. Because with that HFNC support, we could not shift it to the MRI. So mostly we thought clinically, we started it, and radiologically it was.
She was very sick.
Yes, sir. Actually, her respiratory involvement is worrying. Actually, within 1.5 day, this child suddenly. Initially, we thought it could be GBS or what, but
asymmetry was there. Upper limb, lower limb.
Yes, sir. It's actually like ascending paralysis. You were initially diagnosed like doubtful between IVA, GBS, and dengue. One thing that needs the clue is the NS1, but dengue also can cause GBS. But usually they are post.
He had no problems in relation to capillary leak, edema, bleeding. Those issues were not there.
Only blood test proved NS1 positive. Otherwise, we didn't think of dengue initially.
There is no edema, capillary leak, polycirrhosis.
Yes, sir. Nothing was there.
Thrombocytopenia?
Thrombocytopenia is there. That is one clue we could find out. I think 1 lakh. And the next day also it is falling to some 65,000. That is one clue. Then we are sure that it is viral dengue.
Yes, it can be so. Dengue can have no evidence of capillary leak when it is involving the CNS.
CNS, yes.
Many times we have seen isolated, both in dengue and scrub typhus, you get purely CNS manifestation. Investigation will give a clue. but there will not be any other associated features of dengue capillary leak.
Yes, sir.
That is known. Very good. Please go ahead.
Sai, 10 more minutes.
Yes, sir. Yes, sir. I'll finish it.
Yeah.
So these are the way dengue can affect CNS. It can cause simple febrile seizures, encephalopathy, encephalitis, meningitis, GBS, myelitis, I think press and stroke, cerebellar syndromes, anything it can cause. And even eye involvement, you should have a high index of suspicion, especially retinochoroiditis. And it can cause the myositis, myalgia, hypokalemic. How they can cause? It can be a direct viral infection. It can be due to metabolic disturbances or immune mediated. Basal ganglia, thalamus, cerebellum, hippocampus involvement is there. T2 flare hyperintensities, sometimes restricted diffusion and meningeal enhancement. So when will you suspect reduced dengue encephalitis? Reduced level of consciousness, headache, fever, nausea, vomiting, seizures, focal neurological deficit, behavioral symptoms, and some usual symptoms. That is what Sir Narayanappa sir has mentioned. It's not seen in 50% of patients. That is important. And labs will add to your suspicion. That is very important. So clinical and laboratory parameters are important. Neuroimaging, normal. This does not rule out dengue encephalitis. One thing I want to highlight. And yield of PCR studies in CSF is low due to lower CSF viral load. So it should more of clinical and laboratory diagnosis. Management, symptomatic, anti-seizure medication if seizures are present. Manage raised ICP. That is very important. Whatever you do, that viral load affection will eventually come down. But managing the comorbidities, managing the complications is very important. There is no definitive role of corticosteroids. You can give it only in case if you are suspecting immune-mediated manifestations. Clinical examination is important to rule out focal neurological deficit because especially in case of intracerebral hemorrhage or expanding infarct, when you are suspecting stroke, when there is focal neurological deficit, CSF tap should be done with caution, especially if a child has altered sensorium and you are suspecting stroke. That is one important point. These are the clinical clues for underlying etiological agents. Anyone can just take a screenshot that would help you in your clinical in your ICU. I'm not going through in detail. These are the MRI findings. Temporal lobe suspect herpes, 1 or 6, thalamus JE, influenza, brainstem enterovirus, rabies, splenium of corpus callosum. Many viruses can cause. Rotavirus is one thing you should keep an eye on. Temporal lobe, thalamus I have already mentioned. Variable involvement is associated with dengue and varicella zoster virus. You should think of vasculopathy. Splenium, many viruses. That there is one entity called MERS, minimal encephalopathy with reversible splenium lesion. That is one important MRI finding. You will just find a restricted diffusion lesion over the corpus callosum splenium. These are the various common infections causing your MRI findings. So influenza is one important thing where you should look of annex. You can see these target lesions over the basal ganglia. And Japanese encephalitis causing basal ganglia affection. So what is the role of EEG? So diffuse slowing suggests encephalopathy. HSV, you will have periodic lateralized discharges. And if you are suspecting SSPE, there will be periodic complexes. Also, important role is to rule out electrical seizures or non-convulsive status. Now, encephalopathy with the systemic infections, I want to take you through 2 cases. This is Salmonella, 16-year boy with a decreased appetite and abdomen pain, 8 days of illness after, developed ataxia while walking, excessive drowsy, preferring to sleep, cerebellar signs are positive, fever workup Vidal significantly positive, culture revealed Salmonella, MRI showed bright cerebellum, white cerebellum. So it is cerebellitis. This is the child. Look, he is unable to tandem walk. He's a bit swaying at that time. Yeah. So spectrum of enteric infection on CNS, it can cause encephalopathy, meningitis, seizures, ventriculitis is one important entity. Cerebellitis, you should not miss. Stroke can occur. Extrapyramidal syndrome, B6 deficiency is recently also found out. And one more thing is psychological and memory disturbances and behavioral issues. Treatment is antibiotic as per culture sensitivity pattern. Usually you start with third generation IV cephalosporin like ceftriaxone. Duration is for 2 to 3 weeks, preferably IV. Any role of steroids? There is no role. You should consider if there is persistent encephalopathy even after antibiotic therapy. Severe cerebralitis, ADAM or GBS. You give IV, IG. Next is 17-year boy, high-grade fevers, was referred from outside in view of seizure-like activity that was found to be shivering. That is not seizure, actually. On examination in ICU, we found out that he is having cerebellar signs positive. I will depict those later. And skin lesion, there is a SR found. Spleen tip is palpable. He resides in village area. Low platelet count. Scrub typhus positive. So diagnosis is scrub cerebellitis. CSF shows slightly elevated protein. MRI is normal in this child. We treated with doxycycline for 7 days IV. Over 3 to 4 days, all these symptoms disappeared. This is that child. So you can go through these videos one after other. So you can see finger nose test that could not be performed. Next showing dysdiadochokinesia, and here not classical pendular knee jerk, but you can see almost it's coming around 3 to 4 times. And rebound phenomenon can be elicited. And sorry, you could see how is ataxic, and knee heel test we could not perform properly. So all the cerebellar signs you can elicit in this child. So high index of so it's more clinical diagnosis. MRI could be normal in some cerebellitis. That does not exclude your diagnosis. Spectrum, they can cause encephalitis, cerebellitis, meningitis, seizures, isolated cranioparesis, ADAM and GBS. Encephalitis is the common thing. And thrombosis, cerebral vein thrombosis should not forget, and opsoclonus myoclonus has been reported. So presence of RBCs indicates generalized vasculitis, that is the pathophysiology. And nested PCR can identify scrub. We did not send due to financial issues. Cerebellitis is rare. Time interval is essential. Doxycycline is the treatment. If severe, you can add Agitro as well. This is the post-infectious syndrome. Case 1, 7-year boy, fever, multiple seizures in 1 day, had mumps 1 week back. Sibling also has elevated protein in the CSF, 20 cells. CSF is negative, serum mumps positive, IgM. Frequent frontal discharges on EEG. MRI showed bilateral basal ganglia swelling. He was treated with IVIG and MPS. So it's attributing to post-infectious cytokine storm that is causing these basal ganglia swellings. He developed dyskinetic movements, choreoathetoid movements during hospital stay. From day 4, responded to symptomatic management. So IVIG and MPS alleviated the cytokine storm. Tremendous improvement after IVIG in terms of seizure control, sensorium, and abnormal movements. He received oral steroid for 6 months. Slight choreoathetoid movements are present occasionally. This is the follow-up MRI showing subtle gliotic changes in the basal ganglia, otherwise mostly recovered. Case 2, after mumps, he presented with slurred speech, deviation of angle of mouth. Outside adult neurologists treated it like stroke because CT showed lacunar infarct. They came to us with the history of mumps past 1 week. MRI showed basal ganglia swelling. It's like ADAM, treated with MPS for 5 days. Improvement in speech after 3 doses of MPS. After 1 month, it's totally recovered. Repeat imaging showed residual gliotic changes in the left basal ganglia. Third case, after mumps. This is what sir is telling previously. Adam presented with acute onset paralysis, 2.5 years, normal development. He had squint and also facial weakness within 1 day. These are the findings. He's floppy, suspecting Adam. We gave MPS improvement over 5 days. Squint recovered in 1 month. We gave oral steroid for 3 months. He's doing well on follow-up. So mumps can cause aseptic meningitis, brainstem involvement, Adam, ataxia, OMAS, isolated basal ganglia affection, autoimmune encephalitis, or transverse myelitis, polyradicular neuropathies. Management, specific therapies to mitigate the cytokine damage, immunosuppression. Key is to order for MRI brain as soon as possible. That clinches the diagnosis. Maintenance therapy, 3 to 6 months of oral steroids, and supportive care as usual. To end with, I want to take you to an interesting case. Current many cases are coming. It's a newborn, uneventful perinatal period, persistent tachycardia was referred here. So that is atrial arrhythmia, high-grade fever on day of life 2, flushing over the face, excess cry when touched, sepsis screen positive, had 1 episode of seizure. So treated like sepsis. Routine fever checks and chikungunya were negative. Platelets start to fall to 50,000. Facial pigmentation on day 7. You could see hyperpigmentation. PCR for chikungunya virus from CSF sent on day 10 was positive. So we diagnosed this as congenital chikungunya. MRI could not be done due to risk of arrhythmia during anesthesia. 1 month follow-up, better, needs neurodevelopmental monitoring. And if you trace the history back, mother had fever with rigors 2 days before delivery. Serology is positive for chikungunya. So chikungunya, most frequent signs in neonate is fever, pain, rash, thrombocytopenia, lymphopenia, elevated liver enzymes. If seizures, hemorrhage, or hemodynamic disorders occur, the neurocognitive outcome is high. So there will be long-term delays in 50%. Diagnosis is done by detection of chikungunya viral RNA via real-time PCR and IgM or IgG specific serology. RT-PCR is highly sensitive and 98% specific. Brain MRI usually shows white matter lesions and intraparenchymal hemorrhages. The striking pigmentation on the nose is called brownie nose or the chick sign of chikungunya. These are the other skin lesions that you can observe. So how will you manage? Usually supportive, maintain adequate volume. If hemodynamically stable, encourage rehydration by breastfeeds or formula feeds. Also, simultaneous co-infection with dengue should be ruled out, especially in our settings. So this is the approach. So you have to send the CSF sample only after 10 days. Early, if you send, it will be negative for chikungunya. Okay. Lastly, I want to conclude with this slide. Neurocysticercosis is one common tropical infection. So some regular dilemma during treatment, how many days to treat, what to treat, these are latest AOC and consensus guidelines. Routine screening and serology is not recommended. Scolex on neuroimaging is conclusive of NCC. If Scolex not seen, you advise special sequences like MRS to rule out tuberculoma. If not available, repeat contrast enhanced MRI after 6 to 8 weeks. If there is single viable cyst, 10 to 14 days of albendazole is enough. More than 2 viable cysts, combination therapy for 10 to 14 days using albendazole and praziquantel. Repeat imaging is essential after 6 months. If lesion is persistent, retreat with albendazole or combination, your wish. Steroids role only in case of cysticercal encephalitis. After 6 months, you can withdraw if the child has less than 3 seizures and resolution of cyst on imaging. If the cyst has not resoluted on repeat imaging, or if there is calcification present or more than 2 seizures in the past during presentation, long-term anti-epileptic, usually we prefer levetiracetam or oxcarbazepine. Both are equally efficacious. Duration is for 2 years. Take-home messages: CNS infection in children have varied etiology, clinical presentation, treatment course and outcomes, early detection, as Anand Keshwan sir previously mentioned, early identification of disease, CNS infection, early neuroimaging, early diagnosis, and early and complete treatment will give good prognosis. And when you are suspecting immune-mediated phenomenon, early initiation of immunosuppression yields better outcome, and try not to initiate steroids during active viremia phase, preferably. Detailed history taking and clinical examination. Once again, I am telling, detailed history taking and clinical examination is essential to minimize the plethora of investigations and come to appropriate diagnosis. And try to use bedside EEG whenever possible while managing complicated encephalitis, because NCSC or electrical seizures account for majority of the comorbidity or further prognosis in children. These are my references. Thank you.
So, very nice presentation, Sai Deepak.
Thank you,
Really,
sir.
you have done justice, beautiful cases, and very good. You are pediatrician. Yeah, this is what we is expected from the young, dynamic neuropediatrician.
Thank
So
you, sir.
thank you,
So much.
Sai. Nice presentation. Congratulations. Keep it up.
Thank you so much, sir.
Shall I, because I am busy with the conference, I have to go with the guest.
Yeah.
Shall I take leave?
Yes, sir. Yes, sir. Yes, sir. Yes, sir. Thank you, sir.
Kashi, thank you
Yes.
so much.
Yes, sir.
Anil, thank you. Ramesh Bajania, sir. Thank you. Anand Keshav, sir. Thank you. Thank you, everybody. Good night. Thank you very much.
Thank you, sir.
Thank
Thank
you.
you, sir. Deepak, it was a wonderful presentation, elaborated
Thank you.
presentation. Huh?
Thank you,
So,
sir.
Thank you very much. So we'll continue with the next presentation. Dr. Shanti Meher. Can you hear me?
Yes, sir.
Yeah. Shanti.
I stopped the screen sharing, sir.
Yeah.
Is my screen visible, sir?
Yeah, it's visible. It's visible. Introduce yourself, Shanti Meher. So first of all, welcome to the 10th Yuva Cme. So without wasting much time, you introduce yourself and start the program. Sir, Ramesh
Thank
Bajane,
you.
sir. There, sir. Hello. Sir, Ramesh Bajane, sir. Yeah, continue.
Hello.
Yeah.
Yes. So now after this enchanting first session, let us listen what is new from Shanti.
Yeah,
I know
yes, sir.
that he is a very good orator, very good academician, young person, and will do justice to this. Over to Shanti. Not taking much of the time to be around. Thank you.
She's a good academician, sir. She accepted the invitation just on 5 days back only. I gave the topic to her, sir. She accepted the invitation. She was ready for presentation also. It was very happy.
Thank you so much for the opportunity.
Yeah, Shanti, you can introduce yourself and start, Shanti.
Okay, sir. Thank you, sir, for giving me this opportunity and presenting for the first time in the big platform. Thank you, IAP, AP and Yuva Cme, Dr. Kasi sir, Dr. Guru Prasad sir, and Dr. Anil sir. And Dr. I'm happy to be moderated by senior mentors like Dr. Ramesh Bajania sir and Anand Keswan sir. After a very good discussion by Dr. Sai Deepak sir, I want to go to basics of TB latest updates. As sir addressed already, it is like a very severe burden on us, and from the worldwide also we are giving 1/3 burden of TB cases in childhood. So as a common pediatrician, and I want to introduce myself. I am Dr. Shanti Meher. I am working in I am based from Visakhapatnam. I am working in Omni RK Hospital under Dr. Radhakrishna. He is a very great academician. I completed my MBBS from Andhra Medical College and post-graduation from Sir Gangaram Hospital in New Delhi, and completed my fellowship in allergy and clinical immunology from Savita University. Now coming to this, sir, is Coming to this present topic, tuberculosis in children, what are the latest updates? What is my outline of presentation is I want to go by 3 cases, which are the basic cases. From them, I want to cover theory, which every common pediatrician while encountering the cases on daily basis, what are the common doubts they get and how can we address these? It's very basic presentation and that way there are only few points that you can take home from this presentation. Okay, from coming to case 1, this is a 4-year-old girl presented with a complaint of fever since 3 weeks, which is unremitting and unremitting cough of 3 weeks duration. She has taken already, mother taken her to different pediatricians and she used multiple antibiotic courses during the past 3 weeks. And mother noticed, and I'm the 4th pediatrician which she came, and she noticed that she has lost a weight around 2 kgs since she last noted 3 months back. And she also told me that a grandfather has recently diagnosed with a sputum positive pulmonary tuberculosis and started using ATT since past 2 months. And they live in a joint family. Naturally, after visiting so many doctors, mother had doubt that is my child having TB. So how can we address this case? Can we call this case as TB suspect? Earlier, we used to use the word TB suspect for these kinds of presentation. Now, the TB suspect word is not using, and we call all these cases, whether pulmonary or extrapulmonary, presenting similar symptoms of weight loss, persistent fever, and whether in case of pulmonary, persistent cough is there, we call all these cases as presumptive TB case. We do not use TB suspect word anymore, and we call all these cases as presumptive TB cases. What is the risk of infection to the contacts? Usually the risk of infection is more within 2 years is more when exposed to the TB case, whether it's pulmonary and extrapulmonary. Usually the risk is around 30%. And when there is infection risk is around 30%. If the person is exposed, there is risk of lifetime risk of developing disease is there, and lifetime risk of developing disease is more during the first 2 years after exposure to the case. And lifetime risk is more in infantile age group, that is around more than 50%. If the baby is exposed to a source of TB case, they have lifetime risk of progression to more than 50%. And in general age group, it is 5 to 10%. In childhood age group, like from 1 to 5 years, it is 25%. Like as we all know, what is the presumptive TB case definition? If there is persistent fever without a known cause for more than 2 weeks duration, and there is unremitting cough for more than 2 weeks, and weight loss of 5% or no weight gain in past 3 months despite adequate nutrition, or failure of nutritional rehabilitation in SAM children, this should be considered as a presumptive TB case, even though there is no contact with or without contact of the pulmonary TB case in past 2 years. There is not like that there should be a compulsory contact of TB. If there is no contact of TB, also if the above symptoms are present, then we call it as a presumptive TB case. I have done chest X-ray of this child. It is showing some shadowing in the aortopulmonary window and some consolidation, adjacent consolidation also. Why chest X-ray first? Earlier, in suspected TB cases, we used to send sputum sphere for examination of AAB. Now the guidelines have changed. First, after characteristic symptoms, if we find any suspected case, then we'll go for directly radiological examination. Chest X-ray will do. What are the classic findings of chest X-ray that is suggestive of tuberculosis? Is mainly 3 are mainly considered as three abnormalities are mainly considered as suggestive of tuberculosis. Usually, first one is intrathoracic lymphadenopathy. This is usually seen as a dense and well circumscribed ellipsoid or round shadows in the hilar or mediastinal regions. And miliary tuberculosis is diffused shadows, micronodular shadows. They are like snowstorm that maximum can identify. And chronic fibrocavitary shadows, usually in the apical regions, they can be present in other regions also. These three, why I am highlighting these three are characteristic, very much characteristic of tuberculosis, and they are particularly suggestive of TB chest infection. So while interpreting any chest X-ray of presumptive TB case, we should interpret as either normal or abnormal and TB suggestive, and abnormal but not specific, because there may be many mimickers of TB, and in current scenario, usually we will get many children of fever and persistent cough, post-viral bronchitis persisting more than 2 or 3 weeks, and we are getting X-rays with non-specific findings. Then we cannot say this is fever and cough of 2 weeks duration, this is TB. And because of that X-ray findings, we say that X-ray is abnormal but not specific of TB. In those cases. So after getting chest X-ray, what is the next line of investigations? If we see if the X-ray is abnormal and it is not is TB suggestive and not specific, then we need to obtain sample for microbiological confirmation. Initially, patient present with symptoms, then we'll do a radiological survey. Then we'll try to obtain a sample for microbiological confirmation. What are the ways we'll obtain sample in smaller children, because children cannot expect, right? We cannot get good volume of sputum. That is mostly what is the volume required or quality required. So we can take, if the child is able to expectorate, we'll take the sputum. If the child is not able to expectorate, we'll take gastric lavage or induced sputum. If for gastric lavage, overnight fasting is usually required preferably. If the child is not cooperating, we can call them after 4 to 6 hour fast, and we'll take the aspirate. For induced sputum, there is no fasting required. Usually, the sample volume must be good amount of mucopurulent discharge, and it should be of 2 to 5 ml volume, preferably in the Falcon tube. For nucleic acid amplification test, only one sample is required. Earlier we used to, now also we send for smears, 2 samples we'll send, either on same day and different occasions, or can be on different days. For NAT, we'll send only 1 sample only. This is a small data regarding NAT versus smear, FB smear sensitivity in culture positive cases. For the sputum, NAT sensitivity is around 90% compared to smear sensitivity. And for in gastric aspect, NAT sensitivity around 68%. So continuing with our case, her chest X-ray showed lymph node shadow around the aortopulmonary window with accompanying area of consolidation. This X-ray is abnormal and it is TB suggestive. Child is, because of lymph node shadow in the AP window, child is not able to expectorate the sputum, so gastric aspirate was collected and sent for NAT. NAT report came negative, and we routinely do MAN2 for every presumptive TB cases, and her MAN2 report came around 8 mm. That is inconclusive. So I want to tell few words about MAN2 test and its role in current scenario. Usually, the current recommendation is to use a 2-TU PPD purified protein derivative of RT23 strain for all diagnostic purposes. And this should be stored at 2 to 8 degrees and should use with 26 mm gauze needle and 0.5 ml to be injected. We consider MAN2 as positive only if there is 10 mm or more in duration only. In HIV infected cases, 5 mm can be taken as cutoff. As we all know, MAN2 indicates only present or past infection. It is like it is usually as a connotation with source of contact with TB. It cannot distinguish that the patient has disease or not. It will indicate only the patient is infected. Currently, the original strain of RT23 is not available. So continuing with our case has characteristic clinical symptoms. And there is contact history, which is positive. That is, she is exposed to her grandfather recently, who was diagnosed with pulmonary tuberculosis, and her chest X-ray is abnormal and TB suspicious, and her NAT is negative, and MAN2 also inconclusive. What is the next step? When in this case scenario, she is highly, like probably most clinically suspected TB case, but her reports are like inconclusive. What can we do next? If the first NAT is negative, in such case scenarios when there is high clinical suspicion, we'll go for second NAT, probably with better sampling, or we can access like a bronchoalveolar lavage or repeat aspirate. And if there is any peripheral lymph nodes are enlarged, we'll take aspirate from them and send to NAT. And if there is enough sample, we'll send simultaneously for liquid culture, like MGIT. So this is the flow chart. If there is any suspected case, we'll first do chest X-ray. If the chest X-ray is highly suggestive of tuberculosis, we'll go for microbiological sampling collection through either of any of these methods, and we'll send the sample for a nucleic acid amplification test. If the test is positive, this is called microbiologically confirmed TB case. And in that sampling only rifampicin resistance testing will be done. If the rifampicin resistance not detected, the case will start with first line TB drugs. I want to highlight one more point is all microbiologically confirmed TB cases should be tested for HIV. This is for all cases. If the X-ray is non-specific and it is showing non-specific shadows after these symptoms, we'll start an appropriate course of antibiotics. Usually we'll avoid linezolid, and we start mostly with amoxicillin or co-amoxicillin and should be given for 1 week. If the symptoms are still present and there is persistent shadow, we need to look for any other nodes or better way to identify sampling, or look for other causes of presenting similar complaints. If the other causes are ruled out and the microbiological testing negative, we'll treat this case as probable TB. If the chest X-ray is normal and the child having same symptoms, we look for extrapulmonary cause of TB, or we'll try to take samples for peripheral TB nodes, or we'll do CECT test whenever required. So coming to the treatment part, what is new in the treatment part? Right now, the fixed drug combinations have replaced the combi packs and patient-wise boxes that we used to use earlier, and daily treatment is replaced by intermittent therapy. And ethambutol is added in continuation phase because of facing high resistance of isoniazid. Extra drug is added, like ethambutol is added in the continuation phase. In case of non-response or poor response in the intensive phase, earlier we used to prolong the intensive phase for 1 more month. Now we don't prolong the intense phase for 1 more month. We directly subject the case to drug-resistant testing, whether we see the case is still sensitive to the currently using drugs, or any drug resistance have developed. So there is no continuation of intensive phase in case of poor response. And category 2 is removed. All retreatment cases lost to follow-up or treatment after failure, all are evaluated for drug-resistant TB, and they are being treated after resistance is confirmed, or if the case is sensitive to rifampicin, they are treated according to the protocol. Category 2 is entirely removed. And rifampicin resistance is being managed as MDR-TB. This is new. In INH mono or poly resistance, there is separate protocol is being followed in drug-resistant TB protocol. What is the regimen for rifampicin sensitive TB and what are the indications? When do we use rifampicin sensitive TBs? We use 2 months of HRJD and 4 months of HRE. E is added in the continuation phase. When we use, this is all new microbiologically confirmed rifampicin sensitive pulmonary TB cases and new clinically diagnosed pulmonary TB, probably rifampicin sensitive. Why this is clinically diagnosed? Because the NAT is negative and it is new case, probably we see as rifampicin sensitive. All new microbiologically confirmed rifampicin sensitive extrapulmonary TB cases also come under this regimen only. Except neuro and spinal TB, the continuation phase is extended till 10 months. Rest all extrapulmonary TB comes under this regimen, 2 HRJD plus 4 HRE. And as I said earlier, category 2 is removed, like a recurrent TB cases, treatment after loss to follow-up or drug failure. They are all being treated according to the sensitivity pattern. If they are sensitive to rifampicin, they are treated under the same protocol like 2 HRJD and 4 HRE. Like recently, the drug doses has also updated. As we all know, these are the current drug doses and their maximum doses. Fixed drug combinations for intensive phase is like 3 drugs, fixed drug combination dispersible tablets are available. And for continuation phase, this is two drug fixed drug combination available. Ethambutol is not available in dispersible tablet form, so it is added separately in non-dispersible form. This is the recommended doses and pill combinations for the age groups and weight according to the weight. One more point I want to add in TB treatment is adjunctive pyridoxine therapy. Earlier, pyridoxine is advised only to high-risk groups like malnourished and HIV or those with liver and renal failures and MDR TBs. Now, pyridoxine is recommended for all cases who were on INH therapy. Because as the dose of INH is increased and to 10 to 15 mg per kg per day, there is potential to increase the neuropathy and adverse effects. And there is also high prevalence of malnutrition among TB patients. So pyridoxine is advised for all cases as a regular prophylaxis, entire duration of the therapy. It is around 10 mg per day. In drug-resistant TB cases, the dose is higher because of the uses of other drugs like cycloserine, which can also cause neuropathies. So our child repeat NAT was tested positive for MTB and rifampicin resistance was not detected. So she was started on ATT according to the weight band and along with pyridoxine. Her clinical symptoms were improved and cough started improving, appetite improved, and she is good at 2-week follow-up. In the 3rd week, mother called suddenly because of the child having continuous pain, abdomen and vomitings. And she is passing yellow urine and she visited local doctor and for vomiting, she was given symptomatic treatment. And then also the vomitings were not subsiding. So she came to us and on examination, she has jaundice, mild hepatomegaly due to persistent vomiting. Some dehydration is present. Her lab values showed CBC mild anemia with a normal platelets and TLC count. Her LFTs were abnormal. Her bilirubin was 2.8 milligram per deciliter and SGOT as SGPT is more than 10 times normal. So what do you suspect? Because the child, after ruling other symptoms like any fever or any appetite loss, and the child is on ATT, we usually suspect it may be the drug-induced liver injury because of ATT. one point I want to highlight is before starting the treatment only, we should tell the patients what are the important side effects they should notify to us immediately, or they should note immediately before starting treatment only. So that they can come early. So this case might be the drug-induced liver injury. And the usual suspected agents for hepatitis while using ATT were isoniazid, rifampicin, pyrazinamide, paraminosalcilic acid, bedaquiline, and ethionamide. How do you approach? Like if the case is mild and the when we diagnose the symptoms are mild, the TB is not causing much trouble, we can wait. The patient is not serial. We can wait and introduce ATT once the enzyme levels are normal. While if the patient is very sick and we are treating TB meningitis, we cannot stop the drugs entirely. So we use other second line drugs, least hepatotoxic drugs. In that case, we cannot withhold ATT in those cases. If the patients are not seriously ill and after ruling out other like viral infections, viral hepatitis, we slowly reintroduce the drugs one at a time. After 3 days, we'll start with Rifam. If the enzyme levels usually if the enzyme levels are more than 5 times normal and the bilirubin level is more than 2 times normal and enzyme levels are more than 3 times normal, or the child is symptomatic, we'll stop using ATT. Once the enzyme levels are less than 2 times normal, we'll start with the least hepatotoxic drugs among those we are using one by one. After every 3 to 5 days, after assessing LFT, we'll increase we'll add another drug and reassess the kid. This is just a flow chart of hepatotoxicity for isoniazid mono or polydrug resistant TB regimen. As I said, if the LFT elevation is more than 5 times upper limit of normal, or if it is accompanied by bilirubin more than 2 times normal, the LFT level is it should be more than 3 times the normal, or the patient is symptomatic. If any of the 3 criteria met, we'll stop using those drugs and monitor for clinical symptoms every week. And every week we'll do bloods. If the LFTs are falling, then we'll restart the agents. Coming to the second case scenario, this is 10-month-old male baby came with a complaint of mother noticed swelling in the left armpit since past 5 months, which is gradually increasing size. Initially, swelling was hard to touch. Now it is softening. There is no overlying skin ulceration. And mother noticed that baby is not feeling any pain or crying while touching the swelling. History of vaccination on left arm at birth present. And there is no history of contact with TB case. Baby is thriving well, no other systemic complaints, and the birth weight of the child is 2.8 kgs, current weight is 9.5 kgs, and developmental milestones are normal. Rest of the history is not significant. So, what is the most probable, after clinical examination, what is the most probable diagnosis is like it can be the BCG adenitis. How do you approach? By history and clinical examination. The mother telling there is a history of vaccination on the ipsilateral hand, and the baby developed swelling on that hand, and which is gradually increasing. And there is no systemic complaints. If there is like TB, lymphadenitis or peripheral TB, the child must have some symptoms and there must be weight loss, or there can be other systemic complaints also. The child is active, gaining weight and no other symptoms. And even if it is abscess or anything like that, it cannot prolong so long. The symptoms are like chronic symptoms and they are gradually increasing, and these symptoms are not disturbing the baby. So, does any tuberculin skin test, FNAC and NAT help in differentiating TB lymph nodes from BCG adenitis? These tests, usually they do not differentiate both these cases. What is the course of BCG lymphadenitis? Usually it can be a suppurative or non-suppurative. Non-suppurative usually resolves spontaneously, and it takes almost a few weeks to months to resolve spontaneously. Suppression develops in around 30 to 80% of cases. Suppurative lymphadenitis also can resolve spontaneously, but a sinus formation and cicatrization can occur. So this is the flow chart of how to manage suppurative and non-suppurative. In non-suppurative, we'll do nothing. The conservative treatment and follow-up till dissolution will require. In suppurative cases, we'll do needle aspiration, and if the fluid is reaccumulated, we'll do repeated needle aspirations. And if it is not working, then we'll do surgical excision. There is no role of any antibiotics or ATT to treat BCG lymphadenitis. This is third case scenario.
5 more minutes. Try to finish.
Okay, sir. This is a 29-year-old woman who had symptoms of fever and unremitting cough with sputum production, evaluated and diagnosed with pulmonary TB, delivered a male baby at 39 weeks. This is regarding preventive treatment for neonates, sir. So what are the ways of neonate acquiring TB is if the mother has having active TB, both pulmonary and extrapulmonary when the baby is born, or mother has completed the treatment while carrying this baby, or a neonate exposing to any health worker or another contact of pulmonary TB. So when is the high chances of getting neonate affected with TB is when there is the contact having pulmonary TB or meningeal or miliary TB. The low risk with a lymph nodal and pleural effusion. And if the mother completed treatment, at least 2 weeks of the treatment, and baby starts using TB preventive therapy. In neonates, usually symptoms are subtle. We need to do good clinical examination, and we need to search for active TB while sending tests. So when will TB preventive treatment is advised in neonates? Neonates born to mother with any form of active TB in pregnancy or after birth, those neonates need to give TPT, and neonate is exposed to infectious case of TB after birth. In these cases, definitely they should give TPT after ruling out active disease. What is the dose is INH will give at 10 mg per kg for 6 months. Pyridoxine may be prescribed. The baby doesn't need separation from the mother, and she can give breast milk also. In ATT excreted in the breast milk has no therapeutic and adverse effect on the baby. So I want to highlight few points on TB preventive treatment for those for the rest of the family members who are exposed to the index case. Like, what is the target population for TB preventive treatment? That it can be given to household contacts of an active case of pulmonary TB of any age, and people living with HIV, that is adults and children more than 1 year. If the child is if the infant is with HIV is less than 1 year, if he is in contact with active TB, they can be considered for TB preventive treatment. What is the expanded target population is that as I discussed earlier, neonates born to mother with TB in pregnancy, and those on immunosuppressive therapy and dialysis, and who are secondary immunodeficient. For TB preventive treatment, we use 6 months of daily isoniazid or 3 months of weekly isoniazid and rifampicin therapy. If the source is drug-resistant TB, we'll use, if that is MDR TB, which is fluoroquinolin sensitive, we use 6 months daily levofloxacin. This is the tabular form of TB, like what I mentioned earlier. The one point I want to highlight is all household contacts below 5 years of pulmonary TB must be given TPT after ruling of the active disease. If the household contacts are more than 5 years, we'll test we'll test after rolling out the active TB. We'll do TB infection testing like TSTs or EGRAs we will do. If they are positive, we'll consider them with a TPT. These 2 points I want to highlight in this slide. So after we don't want to treat only index case. We'll do like a source searching, and also we want to treat the other contacts also in the family so that we can eradicate TB. Word about universal drug sensitivity. This is the most important aspect in latest updates, because earlier we used to use targeted drug resistance testing. Now we are doing for every case, we are doing at the onset only. We are doing after sending microbiological sample, we are testing for a detection of TB along with the rifampicin sensitivity. If then only from this is like universal drug sensitivity testing for all cases. Now it is doing. If the test is resistance to rifampicin, then we are doing resistance for fluoroquinolines and INH also for those cases. What are the like methods for drug sensitivity or drug susceptibility or drug resistance testing? NAT, we are doing both Gene Expert and TrueNAT. These can be done on any sample. The turnaround time is very less, around 2 years. Line probe assay, this is the turnaround time is 3 days. First line probe assay will detect resistance to isoniazid and rifampicin. Second line usually resistance to fluoroquinolones and second line injectables. And we'll do microbiological culture also. And from that also, we'll do line probe assay after getting the culture sample is positive for a microbacterium tubercle positive. We'll do indirect line probe assay on that sample also for drug resistance for fluoroquinolones and second line injectables. So one more point on CTB. This is like a tuberculous skin test only. This is next generation skin test for the detection of TBI infection. It can deliver like IGRA-like performance in skin test format. The cutoff range is 5 mm. This is micro MTB specific, taking antigens from ESAT6 and CFP10 antigens. It is currently unavailable commercially. These are the two newer drugs, bedaquiline and delamnid, added in the latest regimens for drug resistance TB. So take home points from my topic is, first thing is, after assessing the case, chest X-ray is the initial screening test. Universal drug sensitivity test for all presented TB cases should be done upfront, both pulmonary and extrapulmonary cases from the samples available. Treatment is based on drug sensitivity testing only, and category 2 is eliminated. And TPT, TB preventive treatment for extended targeted population is also new. And prescription of pyridoxine to all patients using INH containing regimen. And all new cases, are whether it is pulmonary or extrapulmonary, should be reported to nodal or district TB centers, whether treating in private sector or public sector. Thank you.
Thank you, Shanti. That was a wonderful, excellent presentation. So you have covered all the latest updates or latest guidelines on the tuberculosis with the beautiful case scenarios. Sir, Dr. Ramesh Bhajan, sir, anything you want to add, sir? Hello? Sir, Ramesh, sir?
రమేష్ సార్ లాగిన్ అయ్యి ఉన్నారు కానీ మరి రమేష్ సార్.
Sir, I think 3 doubts. When should we seriously suspect TB and send for CB-NAT in a child admitted with pneumonia. Any clinical pointers from Gaurav? I think she has told like a presumptive clinical features of tuberculosis. I think that will give an answer to the first question. Why chest X-ray first? Can you repeat, madam? Shanti, you want to answer?
For pulmonary TB cases, we'll do chest X-ray. We'll definitely do microbiological assessments later on. And the thing is, AFB smear is replaced by NAT. In cases where NAT are not available, we are doing AFB.
Kasi, one thing is chest X-ray has become more common, especially in pediatrics, because the nodal tuberculosis is more common in pediatric age group compared to open tuberculosis, like which we see in adults. So even if you sputum for AFB may be normal, but a lymph node with appropriate, like Shanti madam has shown the X-ray, initial X-ray, which has shown a aorta pulmonary window where you have lymph node enlargement with a history suggests of chronic to more than 2 to 3 weeks, which is already treated, the antibiotics are not responding. That gives a more appropriate diagnosis to think of tuberculosis rather than just doing CB-NAT and saying it is negative and you cannot rule out tuberculosis. That is one of the reasons why pediatric tuberculosis is not treated, is not managed well, because the exact diagnosis is difficult compared to adults. Because in adults, it is an open tuberculosis, sputum, collection of sputum, as well as diagnosing pickup of bacterial rate in the sputum is very high as compared to pediatric age group, where nodal tuberculosis is high. So X-ray is better, and I think in the recent national tuberculosis guidelines, revised one, the ESR is not given much importance, and for chest X-ray is the first investigation to do when you're working up for a suspect case of tuberculosis. Even
Sir, and
MANTU
one
is
more
not
thing.
given highlight, given any much importance. Even if MANTU is negative, still you can work up for tuberculosis.
One more point I want to add, sir. Even a bronchoalveolar lavage also will add to the diagnosis. Yeah, because when your clinical features suspects, whereas because all we know, our pediatric tuberculosis is a paucibacillary. So it's very hard to
identify
microbiological. So where we can can have an exact diagnosis. You can diagnose, like gene expert. We can pick up the tuberculosis. So in that case,
I think because of endemicity, any child who has got respiratory symptoms more than 2 weeks, especially fever, cough, for more than 2 weeks, and in a setting where already treated with appropriate antibiotic and appropriate duration, most probably first diagnosis should be tuberculosis in a clinical setting.
Yeah. And the last question, I think, what are the indication of empirical therapy in absence of microbiological diagnosis? I think she has covered all the things in a flow chart. So after doing everything, even if two of radiology, if presumptive symptoms are there, and if failed microbiological, if you think still suspect of tuberculosis, you can start the treatment. She explained in a flow chart, sir.
I think for us, only 2 diseases which are treated on clinical basis, even if there is not proved by investigation wise, is tuberculosis and malaria. Clinically, you are suspecting these things. Still, if you are doubtful, we cannot lose the patient. You can give a trial of after doing all the methods, and still you suspect it's tuberculosis, you can go for a trial of anti-tubercular therapy. Like how we go, fever not responding, if clinical anemia is there, but still not able to identify the parasite. Spleen is there, then where we try anti-malarial. This is one area where you can go for trial antibiotic after ruling out all the possible diagnostics in tuberculosis.
Yeah. As you said, sir, in earlier, in adults, we'll be seeing a lot of gene expert positive cases, sir. But in children, very less likely, because only few of the straightforward cases will have a gene expert positive. But remaining 70 to 80% will go with the clinical diagnosis and diagnosis of occlusion after giving a course of antibiotics, following a course of child, even the history of contact of tuberculosis. I think that is as you said, endemicity. Tuberculosis always should be suspected. So I think Ramesh Bhajane sir is not there. Sir, we'll conclude the session, sir.
Okay. I think both the speakers have performed very well. First speaker has illustrated cases and everything, and second case, Madam also presented beautiful how to approach for tuberculosis and everything. I think it has given a lot of insights in the current recent guidelines in the management of tuberculosis, and also how to suspect the CNS involvement of the tropical disease. Everything. I thank both the speakers for giving. an excellent presentation, and also for all the participants who have joined our Yuva Cme program and make this program a grand success. Thank you, one and all.
Thank you, sir. Thank you, sir. Thank you. So I thank both the speakers for giving their excellent presentations and making their first presentation as a good presentation. So I wish all the best for the future to get more present more presentations at the state and national level. So all the best for the two speakers, Shanti and Dr. Sai Deepak.
Thank you, sir.
Thank you, sir. Thank you, sir.
Yeah. So
Good night.
Good night.